Good morning, everybody. Before we officially start grand rounds, a couple of thank yous and kudos, and of course, Happy New Year. I hope everybody had some downtime and a chance to enjoy the holidays outside of the hospital. And couple of thank yous to Hannah Bay and Steve Irvine. I don't know if everybody knows them, but they are the two APPs who cover the inpatient units at UW Medical Center. And Freddie Yang wanted to just thank them for their overall good work that they do. And I concur, including the care they provided for one of my challenging patients over the holiday week. And then Dr. Yang also wanted to thank Emily Robinson. Dr. Robinson, he noted, as somewhat of a black cloud in terms of the number of consults she gets. And Freddie wanted to thank Dr. Robinson for handling these consults extremely well and being extremely thorough and great to work with. So thank you, Dr. Robinson, and thank you, Freddie, for passing those comments along. And with that, we'll start our first grand rounds for 2004. I'm Howard Chansky. I'm the chair of the University of Washington Department of Orthopaedics and Sports Medicine. And we're going to have a discussion this morning on cervical spinal deformity. And it's going to be led by Brian Vasquez, who's one of our R4 residents, who I believe is going to anticipates doing both a spine fellowship and a pediatric orthopedic fellowship. And he's partnering with Dr. Haitao Zhou, who is an assistant professor in our department, who everybody knows is based at Harborview, and he takes on really complex, traumatic, and elective cervical spine problems. Thank you.
Thank you for that introduction, Dr. Chansky. Good morning. Thank you for having me. My name is Brian Vasquez, and I'm a fourth-year resident in orthopedic surgery here at the University of Washington. Today, we'll be discussing adult cervical spinal deformity with an emphasis on cervical kyphosis. I'm grateful to be joined by Dr. Haitao Zhou, assistant professor in spine surgery at Harborview Medical Center. I have no disclosures. To prime our discussion, we'll start with a case. A 48-year-old male with a history of cervical osteomyelitis, as well as polysubstance use disorder, was referred to our clinic. In what turned out to be an appropriate choice, he purchased a one-way bus ticket from his home residence in Spokane directly to our clinic at Harborview. There he reported to us having a history of severe neck pain with numbness, tingling in both upper extremities, as well as progressive bowel and bladder incontinence over the past month. Radiographs were obtained showing a chin-on-chest deformity with 90 degrees of cervical kyphosis. A CT was obtained as well, showing kyphosis at the C7 and T1 levels with profound end plate destruction, as well as autofusion at several adjacent levels. And his MRI confirmed our suspicion of discitis osteomyelitis at C7, T1 with an epidural fluid collection from C2 to C5. Addressing deformities such as these will be the aim of our presentation today. Setting the stage, we'll begin with background of adult cervical kyphosis. We'll then discuss anatomy and biomechanics, as well as radiographic analysis, goals of deformity correction, and some relevant techniques. Finally, a brief word on outcomes and complications. I'll then turn the presentation over to Dr. Zhou to talk about some complex decision-making in deformity correction. The cervical spine plays a fundamental role in transmitting axial loads from the cranium through the thoracolumbar spine and ultimately to the rest of the axial skeleton. It's essential for maintaining horizontal gaze, for permitting supple head and neck motion, and for protecting important neurovascular structures such as the spinal cord, nerve roots, and vertebral arteries. Cervical kyphosis is the most common form of adult cervical spinal deformity. Patients often present with neck pain, but may also have myelopathy, sensory motor deficits, and in relatively more severe forms can present with esophageal dysphagia when deformity co-occurs with anterior osteophytes. as well as the previously noted chin-on-chest deformity with loss of horizontal gaze. Causes of cervical kyphosis are varied and often multifactorial, but can include post-laminectomy kyphosis following decompression, degenerative kyphosis, proximal junctional kyphosis in setting of a prior thoracolumbar fusion, ankylosing spondylitis, which can result in long anteriorly fused segments and rigid deformity, as well as infections and neoplasm. The cervical spine is a biomechanical structure with 6 degrees of freedom, including flexion, extension, axial rotation, and lateral bending. Global physiologic range of motion in the cervical spine is approximately 90 degrees of flexion, 70 degrees extension, 20 to 45 degrees of lateral bending, and up to 90 degrees of rotation on each side. Regarding biomechanics, torque is the essential concept. Torque is the rotational analog of linear force and is equal to the product of the radius, the magnitude of the applied force, and most relevant to our conversation, the angle between that applied force and the lever arm. In anatomic spine, the center of mass is approximately 10 millimeters anterior to the supratracheal notch, shown here. The effect of gravity creates a forward bending moment around an axis of rotation in the subaxial spine. When cervical kyphosis is present, the center of mass moves anteriorly, creating a larger component of force that is perpendicular to the axis of rotation. This requires greater forces to maintain the head erect, accelerates disc degeneration, results in more kyphosis, and ultimately a destructive cycle ensues. Key to our understanding of each deformity is radiographic interpretation. Global cervical lordosis is measured by the modified Cobb method, in which lines are drawn parallel to the C2 and 7 inferior end plates. Perpendicular lines are then drawn to each of these, and the angle subtended between them is the cervical lordosis. In Hardecker's study of 100 asymptomatic volunteers, he noted an average cervical lordosis of minus 39 degrees when measured in this fashion. The C2 to C7 sagittal vertebral axis helps us characterize the anterior translation of the upper cervical spine. This is obtained by measuring the distance between the C2 plumb line and a vertical line drawn from the posterior superior end plate of C7 and has a mean value of 21 millimeters. Finally, the CBVA, or the chin-brow vertebral angle, is an indirect measure of horizontal gaze, and it's obtained by the line connecting the patient's chin to their eyebrow and a vertical line from the eyebrow to the ground. This can be measured both clinically and radiographically, and following correction, obtaining a neutral CBVA is one of our goals. The goals of treatment for cervical spine deformity correction include restoration of alignment, decompression of neural elements as is indicated, restoration of horizontal gaze, stabilization with the biomechanically sound construct, with the hope that this will facilitate solid fusion, all while minimizing complications. With this in mind, some factors to consider when establishing our preoperative plan include the presence of neural element compression and associated neurologic symptoms. For example, such as if ventral compression is noted, this will usually necessitate a ventral approach. The flexibility of the deformity obtained on dynamic views. The location of the deformity within the cervical spine. For example, upper cervical deformities a few levels above can complicate our fixation plan. The presence of degenerative changes at adjacent levels, particularly at the distal and proximal ends of our construct, as well as bone quality and overall medical complexity and ability to tolerate major surgery. We'll now move on to discussing some essential techniques. With an ACDF, or an anterior cervical discectomy and fusion, an anterior approach to the cervical spine is taken. Resection of anterior structures, including the anterior longitudinal ligaments, the intervertebral disc, and posterior longitudinal ligament is completed. A ventral decompression is done as indicated. Tricortical allograft is placed between the end plates, and fixation is done with a locking construct or multi-level surgery is planned. Correction for a single level ACDF generally improves cervical lordosis by approximately 6 degrees, with an overall improvement in lordosis of 3.5 degrees. Some advantages include the ability to address anterior compression, such as a posteriorly herniated disc, as well as takedown of anterior osteophytes that may limit our correction. Some disadvantages include a high rate of pseudoarthrosis with multi-level constructs unless the posterior arthrodesis is used in addition. Also, that patients may be at risk of vocal cord dysfunction and dysphagia. And finally, that tortuous vascular anomalies can put the vertebral artery system at risk. Shown here is a useful technique for deformity correction where central screws are applied to an overbent plate. As the plate is brought down, overall lordosis is improved. Next is an anterior cervical corpectomy infusion. Here, an anterior approach is taken to the cervical spine. Discectomies are performed at the levels above and below. The intervertebral body is resected and a graft or cage is placed under traction. Anterior cervical plating is then completed. Cervical corpectomy infusion is most helpful when pathology is directly posterior to the vertebral body or if the structural integrity of the bone has somehow been compromised. Disadvantages include that, like multi-level ACDF, isolated anterior instrumentation for multi-level corpectomy has a failure rate as high as 70%, and posterior stabilization is absolutely required. Additionally, that the caudal end plate may be at risk for subsidence and collapse with large deformities and in patients with poor bone. Regarding posterior spinal instrumentation and fusion with or without decompression, patients are positioned prone on a Jackson table. A subperiosteal dissection is taken to the lateral aspect of the lateral masses, but no further. Laminectomies or laminoplasties are performed to address posterior neural element compression. One useful technique shown here involves the use of bivector Gardner-Wells traction, in which a horizontal rope is used to stabilize the neck during our exposure and instrumentation, and an oblique rope is used following osteotomy to facilitate reduction. C2 fixation is obtained in the usual fashion by pars screws, pedicle screws, or translaminar screws as indicated by the patient's anatomy. Standard lateral mass screws are placed from C3 to C6, and pedicle screws are placed from T1 to T2. Foraminotomies are performed at levels where stenosis exists, because as the deformity is reduced in extension, the cross-sectional area of the foramen is reduced and can exacerbate or create radiculopathy. The Smith-Peterson osteotomy is a useful modification, a useful technique done from a posterior approach. This involves complete resection of the superior and inferior articulating facets with removal of the ligaments, lamina, and spinous processes at the desired level. The pedicles and body are left intact, and kyphosis is addressed by posterior compression following instrumentation. Correction expected here is approximately 10 degrees. And the main disadvantage is that the lateral masses may not be robust enough to allow for application of compressive forces to address the deformity, risking implant failure and loss of correction. Finally, a pedicle subtraction osteotomy. With this technique, patients are positioned prone in reverse Trendelenburg to minimize bleeding. As mentioned previously, they can be placed into bivector Gardner-Wells traction. A posterior approach to the cervical spine is then taken from C2 to C5 often. Osteotomy begins with a C7 laminectomy. The lamina spinous processes are removed in block, with a burr used to remove the caudal half of C6 and the cranial half of T1. Resection of the C6 and T1 superior facets is critical, as failure to do so can result in an iatrogenic C8 nerve root compression during closure. The lateral mass of C7 is resected. The pedicles and body of C7 are then decancellated by passing a high-speed burr into the pedicle and then removing the pedicle walls piecemeal. The neck is subsequently extended to correct the deformity. Deformity correction with this osteotomy is reported to be as high as 35 degrees. And this osteotomy technique is most ideally performed at the cervicothoracic junction, secondary to the relatively more safe location of the vertebral arteries at this level, as well as the relatively larger transverse diameter of the spinal canal. Regarding complications and outcomes following cervical deformity correction, these can include those specific or relatively more likely to an anterior approach, which can include vocal cord palsy, tracheal and esophageal injury, as well as graft failure. And those more common from a posterior approach, which include nerve root injury, hardware failure, non-union, and vertebral artery injury. In this prospective multi-center study of 78 patients performed by Smith et al., an overall complication rate of 43% was noted, including 28% of patients with at least one minor complication and 24% of patients with at least one major complication. These included dysphagia, C5 palsy, surgical site infection, and respiratory failure. The combined anterior-posterior approach had the highest early complication rate of nearly 80%. Despite this, studies have noted success, both in terms of radiographically improved alignment, as well as health-related quality of life outcome measures. This study by Tommy et al. Was a retrospective review of 14 different studies, including 399 patients. They noted improvements in outcome measures, including the NURIC score, the JOA score, which is a measure of motor and urinary function. Restoration of horizontal gaze was also included. Here are some references without which this presentation would have not been possible. And I'll now go ahead and turn the presentation over to Dr. Zhou, who will talk about complex decision-making with some specific cases.
Right. Hi, good morning. My name is Haitao Zhou. I'm a spine surgeon based at the Harborville Medical Center. Today, the topic is treatment of cervical deformity. I have no disclosures. And Brian did a good job to give us a review of the cervical deformity. Here's the repeat of normal X-ray, how it looks like. The head is centered. The patient is not in kyphosis, and you have a T1 slope, and then you have a cervical lordosis, which is going to bring the head back to the center of the gravity. This is pretty much like the lumbar spine. We have the pelvic incidence, which is a fixed angle. Then we have the sacral slope, and then you have lumbar lordosis to bring the spine back to the center. When you have kyphosis, then you are having trouble to your posture, and the patient may have some symptoms related with that. And this is a paper published in 2013. Based on this paper, this is how the way we measure the cervical lordosis. Majority of the lordosis is happened between occiput and the C2 level. And from C2 to 7 is only about 10 degrees, which means, if from C2 to C7, I can make a patient pretty much straight, not lordotic or not kyphotic. Patient should be able to compensate. So at the beginning, I want to mention that, subaxial cervical spine deformity is only a part of the cervical deformity. There's also upper cervical deformity that we're not going to pay much attention on today. This is a C2C3 autofusion with the basilar invagination and the brainstem impingement. This patient presented with myelopathic symptoms will need some kind of reduction and posterior fixation to decompress the spinal cord. This is a patient of mine. He presented when he was 29-year-old with severe myelopathic symptoms. He had a really narrow cervical canal at the C1 level. Also, there is a category of coronal deformity in the cervical spine. Likely, this is caused by congenital deformity. It could also be a compensation from a coronal deformity in the thoracic and the lumbar spine. We all know that kyphosis is not ideal for a patient with myelopathy. We all know that if the patient is in kyphosis, that with spinal cord impingement, if we just do posterior laminectomy is not enough. We need to correct the deformity, then do the posterior laminectomy. Like this patient, he was kyphotic. He had a 3-level ACDF. Then after laminectomy, the spinal cord was fully decompressed. So this is a typical patient, showed up with chin and chest deformity. Patient is having difficulty to obtain horizontal gaze. Patient try really hard to extend the neck to be able to function. The patient can also have myelopathy because the spinal cord was stripped to the posterior cortex of the cervical spine. That can compromise the blood perfusion to the spinal cord, and that can also cause direct compression to the spinal cord. Like Brian mentioned, the etiology, we have iatrogenic reasons, which is post laminectomy, and the patient also can have kyphotic deformity from degenerative disease or infection or ankylosing spondylitis. Their symptoms are mainly neck pain, losing horizontal gaze, and the myelopathic symptoms. So the goal of treatment is like most spine surgeries, there are 3 goals. we need to decompress the spinal cord or nerve root. We need to realign the spine, make it reasonable, and we need to stabilize the spine so it won't progress. So the essential techniques we used, Brian already mentioned. I listed 7 techniques here, which is, ACDF, posterior osteotomy, corpectomy, and osteotomy of the ankle-vertebral joints, and opening and closing wedge osteotomy, and the vertebral column resection. So this is a paper also published in 2013, categorized all the techniques, put them into 7 grades. The grade 1 basically is the ACDF, grade 2 is posterior facet release or resection, 3 is a corpectomy, 4 is a complete ankle-vertebral joint release, 5 is opening wedge osteotomy, 6 is closing wedge osteotomy, 7 is VCR. We're going to touch some of those techniques today. So ACDF alone is not very common in kyphotic deformity surgery. Patients rarely have just one level with significant kyphosis. If it's significant enough that I really won't trust just the ACDF plate to stabilize it, I will probably back up with some posterior fixation. This slide showed a post-laminectomy kyphosis on a patient at the C3, C4 level. I placed Casper pins divergently, then put the distractor in, and by just doing that, I was able to reduce some of the kyphosis. And then I distract with the Casper pins, put in the bone graft, and then also put in a plate. At this time, the cervical spine is, between C3 and C4 is pretty much straight. Based on different measurement technique, we correct this patient about 20 degrees versus 15 degrees based on how you measure it. So this is the ACDF is my main tool for cervical kyphosis correction surgery. Every time I see a patient with cervical kyphosis, I want to know where the kyphosis is and where I can do ACDF and straight out the spine. But sometimes ACDF doesn't always work. This patient is a 67-year-old female, was transferred from outside hospital for occiput cervical fusion and the C1 posterior ring resection. That was, from the transfer request. But by looking at this MRI, I think the patient has a kyphotic C2, C3 level because of the boundary of C2. Patient also has a C2 dense fracture, which I'm going to show in next slide. So for this patient, I just do a C2, C3 ACDF to reduce it. Then I got the CT scan, realized the patient had the C2 to C7 fusion, and the 2-3 facet joints on both sides are completely fused. Then I really cannot just go straight to the front. I have to release from the back as the first stage, have to take out the hardware. So also the patient had, C2 screws were all loose at that point. So that was the first stage. I went to the back, released C2, C3 facet. Then I, for the patient, did the C2, C3 ACDF, tried to reduce the spondy, which I don't think I completely reduced it, but I reduced about 80%. And this 2 mid-sagittal cut showed the release of facet joint at C2, C3. In my mind, this is a grade 2 osteotomy. This is a post-op upright X-ray. Patient started walking again in about 3 months after surgery. The CT on this slide is from a not really spine-related study. Again, it's not just the facet fusion that can prevent this from ACDF to correct the kyphotic deformity. This patient I showed earlier had a laminectomy at outside hospital for epidural abscess. Within 5 months, patient developed severe kyphosis at the C3-4 level with cord impingement. The patient was only 34-year-old and was having difficulty to walk for about 2 weeks. So this patient, I also did posterior approach, like I need to release the facet joint, make it not purge to reduce it, then I can do the ACDF. For ACDF, be able to work to reduce the kyphotic deformity, you have to have a mobile posterior elements like the facet joints. Again, we look at this before. This patient, I didn't just stop at the ACDF. I placed screws on the back and backed up. This is the post-op CT and the post-op X-ray. Now, so far we talked about ACDF, posterior release, and the grade 3 osteotomy in that literature is a corpectomy. So this patient presented with a 3-level osteo and pretty significant kyphotic deformity of the C5, 6, and 7. For this patient, I think the right solution is to do multi-level corpectomy and posterior fixation. So I placed the patient supine on the operating table. This is right before we started the surgery. After the exposure, I put Casper pin in C4 and find the disc at the C7 T1, and then place Casper pin in T1, distract, and remove the C5, 6, and 7 body, put in the page to provide the anterior column support and also correct the deformity. I also placed the plate on the front and flip the patient, did a C2 to T2 fixation and the multi-level laminectomy. After the corpectomy, the cervical spine was pretty straight. So far we talked about 3 osteotomies. When we do ACDF, we need to posterior to be mobile. When we do posterior, we need to anterior to be mobile. So what if a patient like this showing up? This is a 54-year-old male presented with neck pain, losing horizontal gaze, and started having myelopathic symptoms like weakness in the arms and a difficulty with balance. Like most patients, I want to get MRI, I want to get the CT, look at the spinal cord impingement, look at the bony structure. So I realized the patient has a fusion between C4, 5, C5, 6, and 7. Then I look at this coronal cut. The patient has ancovertebral joints are all fused, which normal ACDF, we don't really go this far lateral because we now know that the vertebral artery is right next to the ancovertebral joint. But for this patient to be able to release, to do an ACDF to correct the kyphotic deformity, we have to break all this autofused osteophyte. We have to release the ancovertebral joints on both sides. So this is the patient had a CT 2 years prior to presentation. This is the MRI about 5 months before. This CT was about 3 months before his clinical appointment. I put the patient in cervical traction, see how much correction I can get in all the other levels. I got like a traction CT that showing how much correction we can get without doing surgery. Then all the levels that we couldn't correct the deformity, those are the levels we need to work on in the operating room. This patient had about 25 degrees of kyphosis just between C5 and C6 level. So that's gonna be the level I need to pay most of my attention on. This patient, again, I placed supine with a shoulder bump, and his head was like floating, so I put some towels under the head, use traction, then started my way from my surgery from like a C3, 4 level. I did ACDF at the 3, 4. I did the surgery at the 4, 5. Then I started working on 5/6, I couldn't really see the disc, so I used the section to mark the disc level, use Midas burr to find the disc and opened up. I have to go very lateral, like look at the uncovertebral joint and use a small Harrison backwards, just take out the bone, not mess with the vertebral artery. By the end, I put in the ACDF trial that helped me with some correction. I put a plate on the front after the ACDF was done. You can make an argument that without the plate, posterior fixation probably gonna get more correction, but I think on this patient, the extra fixation on the front is well worth it. So now I flip the patient to prone. You can still see the kyphotic at C5/6 level, but when we put in the rods from the back from C2 to T2, the C5/6 kyphosis got more corrected. This is the CT scan showed the release of the uncovertebral joints on both sides. This is the grade 4 osteotomy. If we reference that paper, those are the post-op x-rays. So retrospectively, if I started over again, I'm probably gonna do one more level of ACDF 6/7, because right now the 6/7 is still kyphotic. If I release the uncovertebral joint at 6/7, I shouldn't worry about the vertebral artery too much, and at the base of the cervical spine, I can get even more correction. So this is the grade 4 osteotomy, and sometimes we have to use a combined technique, like this patient that Brian showed at the beginning of his presentation. This is a 48-year-old male presented with severe chin chest deformity. Again, like most patients, I will get CT MRI to look for where the deformity was located. This patient has a kyphosis from C4 to C6, and also like a bony destruction at C7, also superior part of T1. On this CT, I feel like the 2/3 and the 3/4 level looks okay, even though they're not great, but I felt like if we just leave that alone, should be okay for the patient. Again, I place the patient on cervical traction, just to make sure I have access to the front of the spine. For some patients, if their kyphotic deformity is rigid and severe, I may not be able to start ACDF anyway. So this is intraop. I marked my incision, which I used oblique. Then I started at C4/5 level. Again, I used the burr to find the disc and take out the disc, and use the Casper pin to help with the reduction at the 4/5 level. I placed a pretty large graft just for the deformity correction reasons. I normally don't like using big graft for degenerative patients. And then after 4/5, I worked on 5/6. So from these slides, you can see the graft at 4/5. The trial was placed at 5/6 level. This C7 has osteomyelitis, is out-destructed. So after 2-level ACDF, I did a corpectomy at the C7. I didn't want to really do another level because it's going to be really hard to put a plate, stabilize everything. I did only 1 level for this patient. Then this is also, I used the technique Brian mentioned, that I put a straight plate on the front. I started at the middle of the plate, put the screws in, then sequentially I put all the screws in, then I further tightened the screw in the middle, which is at the C6. And bring the spine to neutral. I wasn't even trying hard to give the patient lower doses. Then I flipped the patient, did a C2 to T3 fixation because T1 screw was didn't have good purchase on the left side. I removed that, and this is post-op CT and X-ray. This is a clinical picture of the patient. We really don't have any further studies because the patient left AMA from Harborville after this surgery. So grade 5 is open wedge osteotomy. This is a patient of Dr. Carabello Barba's. Unfortunately or fortunately, I don't have a patient like this, so I used his for a presentation. This is a 29-year-old presented with severe global deformity from cervical all the way down to the pelvis. This is the patient with really high T1 slope. I think this is the patient that can benefit from either open wedge or closing wedge osteotomy. That will change the T1 slope, which Dr. Bella did 2-level osteotomy, a L2 PSO and a T2, T3 open wedge osteotomy. The patient was able to stand up straight. So open wedge osteotomy, which I don't really have much experience, was first published in 1953, was performed under local anesthesia. That was pretty amazing when I read that article. It's a procedure to lengthen the anterior column and shortening the posterior column at the same time. And the PSO is similar to the thoracic lumbar spine. We take out the part of the vertebral body and also all the posterior ligaments. We close down and give the patient lordosis. Vertebral column resection, that's something I really have no idea how to do it for the C7T1 level. Literature always say, if you do the correction at the cervical thoracic junction, you can get better correction for the overall alignment. You don't have to deal with the vertebral artery because that starts at the C6 level, and you can always repair upper extremity function if you paralyze the patient. To me, that's a pretty amazing statement. Complications, this is a major surgery that we do front and the back, sometimes combined. From anterior approach, we can damage esophagus, trachea, vertebral artery. We can give the patient difficulty with swallowing, may end up with a feeding tube, and also patient can have non-union and C5 nerve palsy. Posterior approach, the complications like include infection, C5 nerve palsy, or PSO, they can have non-union nerve palsy and the spinal cord damage. This is how I have. Thank you.
Thank you, Dr. Zhou. Thank you, Dr. Vasquez. We have plenty of time for questions. People can raise their virtual hand, put something in the chat box, or please feel free to just speak up.
Thanks, guys. I have a question. This is Jen Bauer. I'm still unclear what your indications are, Haitao, on anterior versus posterior versus when you would go treat in both. Is it really, it seems like it's the length perhaps of your planned fusion that makes you want to back up anterior and posterior, or is it the amount of flexibility on the extension radiograph? How do you decide where you go when?
So I think it's a combination. If I do multi-levels anterior release or ACDF, because the non-union rate is so high, I'd like to back up from posterior. if I do just one level for that post-laminectomy kyphosis, because the force to kyphose over was so significant, I didn't know if I just do the front part with the plate would be enough. It could be, but I like, you know, in my slides I backed her up with posterior screws and the rods. Basically, the patient had the C3 for laminectomy, and the posterior fixation was C2 to C5. If the patient showed up to, you know, to Harborville the first time for a C3 for laminectomy, I would go extra level above and below the laminectomy site. So, I don't know I answered your question. There are, for this kind of major deformity patients, most of them end up with front back because I needed the front part to correct the deformity, posterior part to stabilize, further stabilize. And
I think that seems like a good summary. You use the anterior to correct the deformity, and the posterior isn't correcting the deformity for you, it's just backing up the fixation.
Right.
Is that correct?
I mean, literature say you can do posterior alone to correct the deformity. In my mind, you have to take a lot of bone to begin with. Also, you put all the stress on the screws. Most of them are lateral mass screws. And to me, that's really not a good setup. I like to do something on the front if, you know, the correction was significant.
What is significant?
If the correction was significant.
What is a significant amount of
curve? The alignment a lot, right? Then if you, like the patient was kyphotic, you know, you can bring him back to straight or lordotic. You don't do anything on the front. You do screws and the rods on the back. I think that will put a lot of stress on the hardware. Potentially could be a setup for failure. I still don't answer to your question.
I guess this is probably where the art comes in. You don't have, sounds like you don't have a number of amount of kyphosis that is present that makes you say that's a significant amount, and therefore you definitely need to go anterior. It sounds like if you're treating them, it's significant, and so you're going anterior and then backing it up posterior.
Yeah.
This is Viral Patel. What I do is there are some kyphotic deformities are flexible and some are fixed. So if you get a flexion extension view in the clinic or in the upright x-ray, and if it is the fixed deformities, is harder to correct from the posterior most of the time. And it puts a lot of stress on the screws and rod. It's flexible deformity, like like a extension correct most of the deformity. I think it's okay to just do posterior sometimes, and that's not going to put too much stress on the posterior instrumentation. I mean, but Haitau's patients are a little bit different. They come in the ER, they have some deformity. You can't get the flexion extension x-rays when they are through the ER. Then you are relying on a CT scan to see whether there's a fixed deformity versus flexible deformity, and then you can decide what to do with it. I don't know that answer your question or not.
Yes, no, that's helpful. Thank you.
Any other questions? This is for Haitao or Brian. You were showing some pretty complex cases with anatomy that you need to really respect, or you could have some catastrophic complications. And given the complexity of the corrections that you're doing in the anatomy, one thing you didn't mention was any role for computer navigation. And so are you using that at all for these cases? At least Haitao is aware that we've had a lot of discussions in UW Medicine about purchasing several $2 million navigation systems. Are these cases you would use those for?
I did not use navigation for any of those cases. To me, the front part for sure, we don't need a navigation. For posterior part, if I can put a decent C2 screws in T1, T2, T3, then put some screws in between, we're in a pretty good shape. So I don't really see that I need the navigation for C2 screws or T1, T2, T3 screws. It's not like I'm not using navigation at all. I use navigation for cervical lumbar deformity that, sometimes the pedicle is like horizontal, parallel to the floor. For me to appreciate that with just floor shot is sometimes it's quite difficult. So I like using navigation for that. But for cervical spine, to me, it's more straightforward than the cervical lumbar deformity.
Are your views typical throughout the spine community? I'm just curious.
I know Rick and Carl won't use navigation for cervical case at all. But we do have colleagues use navigation for upper cervical cases at Harborville.
I mean, same thing for me. I don't use navigation for cervical cases. The only time I probably going to use navigation for cervical deformity is if I'm planning to do a PSO at C7 or T1. I think navigated bar actually helps to go all the way to the anterior and to the side, and helps you to cut the bone the way you want. So that's the only indication for me.
Thank you. I don't see any other hands. So Dr. Vasquez, Dr. Zhou, thank you. That was excellent. Again, Happy New Year, everybody. Have a great week and go Huskies.